Good afternoon. Wow. I usually don't get that kind of command silence in 10 seconds and two comments. First of all, good afternoon, welcome. I have a very brief introduction for you guys tonight, or I should say this afternoon. I already lost a Cosmo in a bet, I think? Not yet, but I know I'm going to lose this bet. Well, one of the things we usually do traditionally when we come to Washington, aside from saying thank you for coming and being able to address the young physicians section is a terrific advantage for me. You are the largest, the most influential, greater than 2,500 members, I think, as a section, and you represent the future of the organization. You are the future of the American College of Emergency Physicians. There's only one recommendation I have is stay as young as you possibly can for as long as you can and have a good time while you're doing it. But I am your vice president of the American College of Emergency Physicians. It's a privilege to serve the membership. I am from New York, the Empire State. I actually am a practicing emergency physician. I have a number of leadership roles in my organization, and I'm the physician leader of an employed group of emergency physicians that numbers over a couple of hundred at this time. Just a little backdrop of the college. We're almost 29,000 members strong. Our finances are great. Our infrastructure in Dallas and DC has been constantly being worked on and is improving. And it's very important, I think, for us to have a good presence in Washington, D.C., because our role and how effective we are here in the near future is going to be really important since, the most significant healthcare legislation since Medicare was approved less than a year ago. And it's on the books, and it's important for us to get involved and be very careful about its rollout and regulation and how it relates to emergency medicine as a specialty, the emergency medicine physicians, our patients, and to make sure that we're careful about fair payment for our services going forward. And a lot of what goes on as Washington is about money and process, whether we like it or not. So it's important to be mindful of that. I think today's one of the largest, or I should say is the largest attendance at LNA ever. There's over 500 people represented here from our specialty. There'll be over 420 visits to the Hill between now and Wednesday. So we have a terrific opportunity to get our point across and to make sure everybody understands what we need to do our jobs and what we need to take care of our fellow citizens and what we need as a specialty. Couple of things that are important. Traditionally, we use membership money in the budget, staff time, membership time, and leadership time to sort of support our efforts going forward. Now, the way we funded it, generally speaking, is out of budget dollars, NEMPAC, which we're going to have a little challenge about NEMPAC here, and that's what we were talking about in terms of the Cosmo that I think Allison's already won. We have I guess there's a long-standing discussion about how many residents and young physicians have gotten themselves into the Give a Shift program versus attendings. So we'll be counting the numbers at the end of this meeting to see if you guys get any closer to the current circumstances where the attendings happen to be winning. But the other thing that I wanted to talk about was the Emergency Medicine Action Fund, and I recognize that I have too much information here to try to get across to you, but I'll do it really quickly. The history of the Emergency Medicine Action Fund, which is another arm, a new tax-deductible arm of the college. It operates within the college for us to give money to the organization so that we could focus on the Accountable Care Act and its regulation and how it has effect on our ability to do our job, the environment we work in, and our finances going forward. So the board and some members who brought the idea to the board over time, and most recently in January, agreed to create a fund where we'd have a board of governors within the college of the Emergency Medicine Action Fund. We're trying to raise $2 million a year for the next several years to have greater impact in terms of our efforts in Washington, D.C. to bring things home to our membership and to our patients that we think we deserve. It turns out we've actually been very successful. In less than 6 months, we've raised $600,000 in donations to focus on additional funding, aside from NEMPAC and EMF, additional funding that is not earmarked for political candidates, but it's really earmarked for focusing on regulatory issues that are unfolding at Health and Human Services and in Congress that's going to affect our day-to-day activities and our work with our patients. And how we are perceived as emergency medicine specialists is a real issue. And some of the activities going to be focused on is editorial board visits with significant communications and media outlets so that we can actually get our point across. You know, right now we're perceived as unnecessary, very expensive, and doing lots of tests. And as you might hear from a lot of your friends, we're not getting a lot of additional attention and a lot of additional funding right now. And it's up to us to sort of turn the tide. And whether we like it or not, the way that works in our country, and not necessarily only in the American political process, in any business, is to actually put some work and some money and some effort behind it. And I think that we've come up with a plan that will be satisfactory and successful, and we need all the membership to actually step up. Now, if every member in ACEP gave $100, that would be an additional $2.9 million a year. We're only looking for $2 million. So for those who can't afford 100, we'll take 30, 40, 50. And at our place, we even asked all the residents to contribute as much as they can, or $5, $10, $15. So we have a singular effort, and everybody's working towards improving our situation. If there are any questions about the Emergency Medicine Action Fund, it would be important to bring it up at this time. You know, there are some really significant things facing us going forward. The looming SGR, which looks like a 30% pay cut this time around. The specter of bundled payments and accountable care organizations, which is going to change our relationship in terms of how we actually bill for services and how our services are valued. And it's important for us to have a significant plan and to have some strength and some urgency in the process as we go forward, so that you all are well represented and we can do what we need to do for our patients with proper resources in a proper environment. I have quite a bit more to say, but I'm going to kind of stop right now. Just if there's more information you want about EMF, there are many of us around who can give you that information. It's proposed that there are going to be 17 board members on the Board of Governors. It is a organization within ACEP. It is subordinate to the membership and the board, so that this Board of Governors can't run off with your money and do whatever they want. They have to do what that's some things that are aligned with our strategic goals and objectives, so it's not a renegade group within the organization. I think there's been some confusion about that, and I want to make that clear. And, it's a restricted account. You can donate to that account specifically. It is tax deductible, and we'll be focusing on activities that are, as I said again, not money that is earmarked to donate to political candidates, but more money to work toward consultative services, legal services, strategy, public relations, and the like. So I actually think it's a great idea. Everybody should jump on board, and I think it's going to be, this is essentially about you guys. It's about you and your future. We are working hard to secure our future, and guys, at the end of the day, you guys are the future of the college. So I would implore you to engage, cooperate, and donate as much as you can. Anyway, I'm going to stop now. I want to thank you all again for coming and helping to represent our great college and our patients. Have a good time in D.C. Don't get in any trouble. There are plenty of events to go to today, tomorrow, and the next few nights, and I look forward to seeing you all there. And at this time, I'd like to introduce your president, Nathan Deal. Come on up and carry on the rest of the program. Thanks. I hope that was satisfactory. Sorry I didn't tell you a joke.
It's okay. He will.
There you go.
Does that work?
The podium mic is hooked up, right?
Yeah.
Well, welcome, everybody. I don't want to take up too much of your time, but I just want to add a couple of quick announcements for you. First of all, to echo what Dr. Salmon was saying regarding the Emergency Medicine Action Fund, I think it's a great opportunity for us to, again, engage our colleagues in Washington and start influencing some of these regulatory changes that are going to be going on. EMRA is excited to be a part of the new Board of Governors as one of the stakeholder organizations. And one of the key things that we realized was that the people that are in this room today are the people that are going to inherit the specialty from the physicians that are working out there now. And so the rules that are going on right now, the decisions that are being made in Washington right now are going to affect our practice quite a bit in the years to come. And so for that reason, we did donate to the Emergency Medicine Action Fund, and we're going to be on the Board of Governors and representing the residents, the young physicians, and looking for the future of what kinds of things, what kinds of rules and regulations we'd like to see in the practice in the future. The other quick announcement that I want to make is if you haven't picked up a copy of this book, we do have copies on our table over here. This is our new Emergency Medicine Advocacy Handbook. The first edition of this book came out a few years ago, and this was something that Nathan Schlicker put together. And he, with the help of Allison Haddock, Nathan, if you don't mind standing up for a minute, two of them put in a lot of work to put together this book, and this is a updated edition that has a lot of interesting information about advocacy, how to work with your lawmakers in Washington, and what kinds of regulations and rules affect the practice that we practice under. And we do have a lot of great authors that put together a lot of great chapters for this. So if you did write a chapter in the new Advocacy Handbook, would you mind standing up so that we can recognize you? One final announcement of the book: if you notice on the first chapter, there is a great quiz about some interesting facts about emergency medicine. The only downside to it is that the answer key is wrong, just like every great test. So we will have copies of the correct answer key that we can hand out later on. So don't take the test yet. Read the rest of the book and then come back and do the test a little bit later on. So without any additional announcements, I'm going to introduce our first speaker, Dr. Allison Haddock.
Thank you.
Welcome, everybody. I'm glad you can all be here today. This is a record attendance for residents as well at the Leadership and Advocacy Conference. I'll be delivering our first lecture today on Introduction to Advocacy, just to kind of lay out some of the building blocks that I think are going to help you to have background on before the rest of the conference. I'm a fourth-year resident at the University of Michigan, and I've been the legislative advisor since this fall. So why did you come to this conference in DC? For some people, it might be the weather. It's supposed to be 88 degrees out tomorrow, and you can't really argue with that. You might love schmoozing. This is a smaller conference. There's a lot more opportunity to meet people, both residents and attendings on many levels. And someone may have paid you to do it. Hopefully, a lot of you are here through funding through the Chairs Challenge, which is the challenge that EMRA issues to department chairs, asking them to send 1 or 2 residents from their program so that they can learn more about advocacy here. But some of you may have more focused issues that you're concerned about. You might be curious about healthcare reform. It's been getting a lot of press. Hopefully you want to learn more about how that's going to affect emergency medicine. There might be a specific issue that you care about and want to make a difference with regards to that issue. And you may be interested in developing leadership skills for the remainder of your career in emergency medicine. This is the time to get started. So for today's programming, we're going to start out with 3 lectures. So I'll be providing the Introduction to Advocacy lecture. Nathan Schlicker, editor of the Advocacy Handbook, will be also having a lecture right after mine on current issues in health policy. He was the immediate past legislative advisor for EMRA. And then Ethan Booker gave an outstanding lecture on healthcare economics last year. He's a young physicians section member, so we've invited him back to give us that background. We'll have a short break after that, and then we're going to come back for roundtables. We've picked some hot topics in emergency medicine advocacy, and we've distributed the EMRA board members and some YPS volunteers to host these roundtables to give you an opportunity to get a little immersion and have a small group feedback session where you can ask questions that you might have about these topics and learn a little bit more about something really particular. After that, the Communications Center will be delivering a workshop on how to deliver powerful presentations. And then the moment you've all been waiting for is the reception, underwritten in part by Team Health. It's the resident and YPS reception, and it'll be held from 6 to 7 on the patio here. We'll be giving out drink tickets for that event at the roundtables. But there's more. Tomorrow at 7 o'clock, Nathan Deal, our president, who you just met, will be hosting a breakfast that I hope all the residents can attend. And then there will be a huge number of outstanding speakers. We have Joe Hack, who is a member of the American College of Emergency Physicians, who was just elected to Congress as a representative from the state of Nevada. And he'll be addressing us about how he's been working on healthcare reform in his time. Carolyn Clancy is the director of the AHRQ, and she'll be talking about research in emergency medicine and quality measures. And then Stephen Stack will also be talking to us about health policy issues. He is on the AMA Board of Trustees. He's their secretary as well as an emergency physician. And then Tuesday is the Hill visit, kind of the moment we've all been waiting for. We're going to have some sessions on what we're talking with Congress about, what our active issues are right now, and then everyone will be sent out to meet their congressional leaders and really discuss with them the issues that are influencing us most as emergency physicians. But we're going to start out here by defining advocacy. What does it mean to be an advocate? What does advocacy mean? And what are the crises that we're trying to deal with right now? We're going to talk about how those led to healthcare reform and how we think that healthcare reform is going to influence us as emergency physicians, and then talk a little bit more about your opportunities for getting involved as a resident and young physician. So is advocacy the same thing as politics? Often people kind of imagine it that way, thinking about going to the Hill and lobbying and advocacy as being the same thing. But I'd argue that really it's not. The definition of advocacy is active support of an idea or cause, and there's nothing political about that. And who performs advocacy? It's everyone. It's all of us every day. We're acting as advocates for our patients and our specialty. You just need to think about what you're doing in a slightly different framework to understand that that's what you're doing. So here's some examples of the kind of advocacy we do. We negotiate with consultants, we're lining up visits and outpatient visits, inpatient consultations with them, arranging for them to come in and help out our patients. We're working on other resources, calling the social worker to get them hooked up with Medicaid. That's acting as an advocate for them and their interests, not just in this emergency visit, but in their healthcare in general. We're educating them about things like children's car seats and smoking cessation, and through that being involved in public health efforts and kind of advocating for the health of our communities. And then we're acting as representatives of the emergency department as a functioning whole, and we're at hospital boards and medical staff meetings looking for solutions to crowding and boarding and trying to figure out how we can let our emergency departments function better within the hospital and acting as an advocate for our specialty and our group. And then we're also working on the legislative arena. There's state laws, there's federal laws, there's reimbursement issues, and there's regulatory issues, and we're working on all of these things as advocates for our specialty and our patients. Why does this all matter? Our patients. We care for some of the most vulnerable people in our society at their time of greatest need. The people who come to us are sick, they're worried, they're concerned, and they really need our care, and they need to be given that care within a system that's working for them. I would also argue that as physicians, we have a role that extends beyond just the care that we're delivering to one immediate patient in one private exchange. We also have a public role as physicians. And one article had a definition I liked. It defines it as advocacy for and participation in improving the aspects of communities that affect the health of individuals. So that really addresses the public health efforts that we're involved in, as well as making sure that people have insurance and access to care, both regular medical care and the emergency care that they need. But we also need to be advocates for ourselves. All physicians are in a situation where we get into a lot of debt in order to do what we do, and we're doing what we do because we love our patients and we love our careers. But we need to make sure that we're getting treated fairly within the current system. And emergency physicians are an especially vulnerable group because of one law, and that law is EMTALA. This is the Emergency Medical Treatment and Active Labor Act. It was passed in 1986, and it mandates that we must deliver emergency care to patients regardless of their insurance status, regardless of immigration status. If someone arrives on our door in a medical emergency, we're going to deliver that care. And emergency physicians were involved in passing this law because they were being told by hospital administrators, we don't want you to care for that patient. Send them to the public hospital down the road. And emergency physicians said, that's not right. That is not the right thing. But now we're faced with an unfunded mandate where we're told by the federal government we have to care for these patients, and we're not provided a method of funding the care that we deliver. We're the safety net. The Journal of or the American Medical Association did a study where they looked at what kind of care physicians were delivering on an unfunded basis. And they found out that the average physician had about $12,000 in bad debt, meaning uncompensated care that they were delivering. That's the cost of the care that they were delivering for free. What do you think that number might be for emergency physicians? $12,000 is not small change, but for emergency physicians, 10 times as high, $138,000, according to the calculations that they performed, of care that's just uncompensated, pro bono, bad debt. And this is why it's such a problem. So this is the percentage of non-elderly uninsured Americans. So in the US, the vast majority, not 100%, but most people over the age of 65 are covered by Medicare. So we get compensation through Medicare for the care that we deliver to them. In 1994, not on this graph, but there were about 36 million people who were uninsured. So it was not a tiny number, but it's just been climbing. So the latest statistics are from 2009, 50 million people without health insurance. And the uninsured are not just, people who aren't working and aren't caring about their health care. When they look at the percentage of people who have at least one full-time worker in their home, it's 60% of people. They're not making a ton of money. They're either below or near the federal poverty line in the vast majority of cases. But they're young people. This is 17% of them are children under the age of 18, and another 40% are under the age of 34. So these are really people that are just starting out on their careers and their jobs and aren't able to get health insurance in our current system. So that's part of the crisis of coverage that we have. The next problem is a crisis of cost. How much do you think the U.S. spends on healthcare each year? So millions of dollars, hundreds of millions. I want everyone to kind of try and think of a figure in their heads. What do you think this number might be? Is it $1 billion? $10 billion, $100 billion. I mean, we're getting to the point where these numbers are just so astronomical, you can hardly imagine them anyways. $1 trillion? $2.5 trillion. That's $8,000 for every American, and it's about 17% of our gross domestic product. So moving towards a fifth of our economy we're spending on healthcare. This is equivalent to the size of the economy of the United Kingdom, $2.5 trillion. This is a problem that sets us apart from other countries. So if you look in the 70s, everyone was kind of grouped together. The United States is that sort of yellow gold line. And then as time went on, we started spending a little bit more than other countries, and then a little bit more, and then a little bit more. Until we got to 2006, where we're almost doubling other countries on what we spend as a percent of gross domestic product. So it's not just that we're a rich country. This is looking at percent of gross domestic product, how much we're spending. And then there's the question, what are we getting for the money that we're spending? Are we having better health outcomes than any other country? And it's a very, very difficult thing to measure, but one sort of proxy for your health outcomes is life expectancy. So the United States, when compared to other countries for life expectancy, doesn't do that great. There's a lot of factors other than healthcare spending that go into life expectancy, but it's something that can be used as sort of a rough measure of quality. So the bar graph is life expectancy. So we're down with Denmark and Cuba, not up where Japan is. And then the purple line is spending. So we're spending a very distinguished amount more money than all those other countries and not having a ton to show for it. So this was the basis for healthcare reform. We have three crises. We have a crisis in coverage. We have 50 million people who don't have health insurance. We have a crisis of cost. We're spending more than any other country, and we're not able to afford it anymore. It's driving up our deficits and our debt. And we have a crisis of quality. People are being injured by medical errors, and we're not sure we're getting better outcomes than other countries that are spending much less. So this is what led to popular support for the concept of healthcare reform, and it made it a major part of the 2008 elections in which President Obama was elected. So on March 5th, 2009, he took on this project, called together a group of lawmakers, doctors, hospital officials, patient advocates in the White House, and he said, we're going to solve this problem. We need to come up with a solution. And he tasked the Congress with coming up with a bill that would help solve some of these problems, particularly the crisis in coverage. So this is the very convoluted process by which our Congress was able to come up with a healthcare reform bill. So if you look at the House committees, there's 3 House committees that are involved in creating legislation for healthcare: the Energy and Commerce Committee, the Ways and Means Committee, and the Education and Labor Committee. So I encourage you, when you go visit your congressman on Tuesday, to learn what committees they're on, because that'll tell you a little bit more about how involved they are in originating healthcare legislation, although, of course, everyone votes on it in the end. So each of those committees came up with a bill in July, and then the House combined those 3 bills into one in late October. In the Senate, the process was a little bit slower. They had two committees, Finance and the Health Committee, the Health, Education, Labor, and Pensions Committee, and they each came up with bills and then combined them into one in November. Things moved a little bit more quickly in the House because of the Democratic majority. They had a one day of floor debate, and then on November 7th, they passed that combined bill in the House. In the Senate, things were a little dicier because there wasn't as strong of a political majority, and there was a filibuster requiring the enclosure of cloture, but on December 24th, on Christmas Eve, the Senate was able to pass their bill as well for healthcare reform. Then negotiations between the House, Senate, and President had to take place to combine these two bills into something that was mutually agreeable to both the House and the Senate. On March 3rd, 2010, Obama held another conference with key policymakers and heads of medical groups, and while we weren't at the 2009 conference, EMRA and ACEP were both represented at the 2010 conference. So that's Nathan Schlicker, who was the EMRA legislative advisor at the time, Sandy Schneider, who was the president-elect at that time and is now our president, Bruce Auerbach, the chair of NEMPAC, and Angela Gardner, the ACEP president, all preparing to go and hear Obama speak about the new bill. So that bill was then passed. The Senate passed the House bill, and that was signed into law. And then to create an area of complete agreement, a reconciliation bill was also signed into law. So when people refer to the Affordable Care Act, they're referring to the combination of the initial bill that was signed by the House and the reconciliation bill. And those two together form healthcare reform as we now know it. So there's already been some parts of healthcare reform that have been implemented. You may have heard that children can now remain on their parents' policies until 26 years of age, which is great for those people just starting out in jobs that might not offer health insurance. They can now stay on their parents' plans. Pre-existing conditions are no longer a basis for insurance companies to reject children. They have to offer a policy to all children who apply on the open market. And some states have started up high-risk pools so that people who have pre-existing conditions and would be refused by insurers have an option to go to for health care. There's some tax credits for small businesses that are offering health insurance to their employees, and there's some rebate for seniors who are falling into the Medicare donut hole. Medicare prescription drug coverage was passed by Medicare Part D in 2003, but there's an area where people are not receiving any coverage for their medications, and so this is helping seniors to not be as badly impacted by that legislation. They've also changed regulations for insurance companies so they can no longer place a lifetime benefit on a lifetime limit on your benefits. They can't say, you know, we've spent $1 million on you, we think that's enough, good luck finding some other health insurance. And it also bans rescissions. So an insurance company can't say, well, we've been providing you with coverage, but now that you're sick, I think there might be this loophole that we found, and we're not going to give you coverage anymore. That's not allowed. And then quality measures have been expended, primarily through Medicare. They're looking at more ways to measure the quality of care that's being provided and reimburse based on that. But the future is where it's really going to change some of those coverage issues that I was talking about in my earlier slides. So starting in 2014, there's going to be an individual mandate that says every American must have health insurance. And if you don't have health insurance, there's going to be about a $700 tax penalty that you're going to have to pay. Pre-existing conditions are going to be eliminated for everybody. Insurance companies are not allowed to base your premium on your health status or your gender, and they are obligated to offer coverage to any private individual who applies. So the projections are that in 2019, this is going to cover 60% of the people who would otherwise be uninsured. It's going to cost about 4% of that $2.5 trillion budget of health expenditures, and it's supposed to cut the deficit because of some cost-cutting measures that I'm going to address in the next upcoming slides. So this is a look at projections for 2019. What would happen to healthcare coverage for non-elderly individuals if we didn't have healthcare reform? So this is the estimate without healthcare reform. That 50 million number anticipated to climb to 54 million by 2019 if the ACA was eliminated or if it had never existed. With healthcare reform, that number is going to drop, hopefully, to only 23 million. These are all projections. You never know exactly what's going to happen, but that's the goal. And if you look, ESI is employer-sponsored insurance in this slide. The number of people with that private employer-sponsored insurance, the kind that we're probably all most familiar with, is what we've had in our families, is only going to go from 57% to 56%. So still remaining the bedrock of how non-elderly Americans are getting health insurance. So those 50 million people who would have been uninsured without reform, what's going to happen to them? So 40% of them are still going to be uninsured, and we're going to talk about those people in the next slide. But the other group of people, 29% of them are going to have public coverage. Medicaid's going to be expanded to cover everyone making less than 133% of the poverty line. And that has pros and cons for us, but what it really means is that more people coming to us are going to have some kind of health care coverage. Medicare may not be the best, or Medicaid might not be the best or what we'd like for them, but at least it's something. 17% of them are going to be on these non-group state-based healthcare exchanges, and then a few more are going to be offered employee-sponsored health insurance, so to expand those numbers a bit. So those who are remaining uninsured under healthcare reform, who are they? So 38% of them are Medicaid and CHIP, which is the Children's Health Insurance Program, sort of a state-based pseudo-Medicaid for people making too much money to qualify for Medicaid, but still too little money to probably be able to get insurance on their own. So 38% of these people are eligible for Medicaid or CHIP, but they haven't filled out all the forms, jumped through all the hoops, and lined everything that they need to line up to get that coverage. So we still need to work on them and how we can expand coverage to them. 28% of them are going to be subject to the mandate, but saying, you know what, I'm just going to pay that tax penalty instead. I don't support this. Going to be a few Tea Partiers in there who are saying, I am not jumping on this ship. 8% of them are going to have an affordability exemption. If your insurance costs more than a certain percentage of your salary, you are not required to have it. And then 26% are going to be undocumented immigrants. So that's likely to continue to be a bit of a problem for us in the border states, but at least we're making some headway. So those state-based health insurance exchanges I was talking about, they're for individuals and small businesses, and they're going to offer tiered health plans, bronze, silver, gold, and you can decide how much intense healthcare coverage you want to get and how much you want to pay for it. Higher tiers are going to be more expensive, but also offer greater coverage. And so that's the way they're going to regulate benefits. And then there's going to be subsidies for premiums for people who are making, who are low income, but not so low income to qualify for public care. And they're affording all of this and still claiming to cut the deficit by having some cost offsets. Medicare Advantage is a program that was created in the 70s that allows private insurers to administer Medicare to beneficiaries as opposed to the public fee-for-service plan that we've had traditionally since 1965. Initially, it was thought that this would help control costs and cut costs, but they've actually found they're spending 14% more on people who are getting this privately administered Medicare. So by eliminating that, they're anticipating that they're going to save hundreds of billions of dollars over the next 10 years. Medicare provider payments, potentially including physicians, are going to be cut. And then there's some various taxes on tanning salons, on high-income Medicare beneficiaries, and then there's tax penalties for people who choose not to have insurance that are going to make a little bit of money for the government to pay for this. Now, there are a few provisions in the Affordable Care Act that are specific to emergency medicine and provide specific benefits for us. So the Essential Health Benefits Package is going to be the lowest tier plan you can get on that state exchange and the minimum benefits that an insurance company is required to offer, and that's going to include emergency services. And they're not allowed to have high out-of-network copays for that either. The copays need to be the same in-network and out-of-network, and they need to provide coverage for emergency care. The prudent layperson standard is expanded, and this is a standard that says that if a prudent layperson thinks they're having an emergency, so if Joe Schmo is out there and has some chest pain and thinks he might be having a heart attack, and he goes to the emergency department, and you work him up, and it turns out you think it's probably reflux, and he's probably going to be okay, his insurance company is not allowed to then go back and say, hey, you went to the emergency department for reflux. We're not going to cover that. He was a prudent layperson who thought he was having an emergency, so his insurance company needs to cover that. That's currently in act already for public health care, Medicare, Medicaid, but this is now being expanded to privately covered individuals as well. And there's a little bit of funding in there for emergency medicine research and for regionalization too. But these are not the only issues, unfortunately, that we're still facing in the coming years. One big issue that you've probably heard something about is the sustainable growth rate. So this is the Medicare's formula for physician reimbursement, and it is highly flawed. It was established in the 90s as a way of trying to control costs in Medicare, and initially it was saying that physicians should be paid more each year. So that was okay, and through 2002, we were getting little percentage increases in what we were getting paid. And then since 2002, it's been mandating pay cuts for physicians every year. Now, this hasn't been very popular with seniors or with Congress, and it's been patched repeatedly since 2002, including 5 patches passed in 2010. The last patch lasts through January 1st, 2012, when we're scheduled to have a 30% pay cut in all physician care delivered to Medicare beneficiaries. This shows how the updates that we've been getting. The updates we've been getting are the red line. That's been the actual updates, not the SGR updates. And the blue line is sort of an inflationary index. That's the what Medicare thinks that it's costing doctors to deliver care to patients. So that's been rising, and the amount that they're paying physicians has not been rising with it. And it hasn't been very effective at controlling costs. The black line is spending per beneficiary in Medicare. So that spending has continued to rise while they've been trying to keep spending on physicians under control. But you can also see the red line does not make up a very high percentage of the black line. The little updates that we've been getting are not what's driving up Medicare costs. So we need to try and find a solution to this, but the problem is it's too expensive to fix. Congress right now is saying that in order to pass anything that will cost any money, you have to come up with that money through either tax increases, although now those are even potentially off the table, or cuts to other programs. And it's hard to find a program that has $400 billion just sitting around waiting to be taken for physician payment. So this is going to be a big issue in coming years. Another issue is liability reform. And I'm going to be very brief on this because I know Nathan's going to address it in his lectures. But we're paying high malpractice premiums. Verdicts are a lottery. They're not going to people who are in the greatest need or had negligent care delivered to them. And defensive medicine is another driver of increased costs. So there's a lot of possible solutions and proposals that are on the table for how we can try and address this. Caps have been fairly effective in some states. There's talk of creating safe harbors for evidence-based medicine, where if you can show that the care that you were delivering was based on evidence, you shouldn't be liable for bad outcomes under that care. There's talk about health courts to try and get groups of people who really have experience and expertise in this to make the decisions, and qualifications for expert witnesses. But for emergency medicine, special consideration for EMTALA-related care is really high on the list. We're delivering a different kind of care in emergency situations that we're not being compensated for. So there's talk that maybe our legal standard of liability should be a little higher standard of negligence for care in the emergency department, both delivered by us and by our consultants delivering that care. This is a little bit more popular now with a Republican Congress, so it's probably something we're going to be talking about on Tuesday. Now, the Affordable Care Act put in $50 million for state demonstration projects, which is not a ton of money, but could get us somewhere. And it did expand the Federal Tort Claims Act to all free clinic personnel, which means if you're in a free clinic caring for someone and that person wants to sue, rather than suing the free clinic personnel, they're suing the federal government. So since that got expanded, we're saying maybe that should be expanded for emergency care as well. We'll see what happens. But these are not the only issues either. There's still more. Access to care is an issue, overcrowding, boarding, workforce shortages, especially in rural areas. And so these are some of the issues we're going to be talking about in the roundtables later this afternoon in small groups to get you an opportunity to ask your questions and interact about these issues. So what can you do? I urge you to get involved. So these are some different organizations you can get involved in. Emergency medicine specific organizations, as well as some other national groups representing doctors of multiple specialties. EMRA has been around for 36 years representing residents. We've got more than 9,000 members. The Advocacy Handbook is a great way to learn more, reading those chapters and sharing it with your fellow residents. The Health Policy Committee held a great meeting this morning, and if you're interested in being involved in that, I urge you to apply. And then there's also the EMRA ACEP Health Policy Mini Fellowship. Application deadline for that is July 15th. For all you residents out there, it's a month-long elective in Washington, D.C., where you get to work with the ACEP office staffers and really get to know what projects they're working on, what they're talking with our congressional leaders about, and really get involved in a lot of their projects in a great way. If you have any questions about it, feel free to contact me or Erin Schneider. She's our Health Policy Committee chair right there, and she also recently completed the mini fellowship. So it's an amazing opportunity. I strongly encourage you to consider it. Of course, ACEP has many opportunities as well. The 911 Legislative Network, free to join. It's one email a week from Jeannie Slade. She updates you on what Congress is discussing, what regulatory issues are active. We're going to have some sign-up sheets for that for you later if you're interested. And then also if there's something where we need to lobby our congressman now, they'll send you out an email blast saying, please call Congressman, please send this email, visit them, and talk with them about this important issue for emergency physicians. We have a speakers bureau and media training for those of you who might like to write a letter to the editor or speak to a local news network about some of these issues. Of course, the ongoing efforts of the DC office. And then there's some ACEP committees that, especially as you grow more and more involved in ACEP, I would urge you to get involved in, including the Federal Governmental Affairs Committee, the State Legislative and Regulatory Committee, and the Medical Legal Committee. They're doing some great work looking into these issues and driving our advocacy and policy agenda. NEMPAC was alluded to earlier. This is our competition with the attending, so I hope everyone can step up and throw in a few bucks. They have 2-year election cycle fundraising and raised more than $1 million in 2010. And in the last election cycle, this is how we compare to the other physician PACs. So we are right up there. Orthopedics, anesthesia, and radiologists still managed to raise a little bit more money from their members, but we are catching up, especially to the radiologists, with $1.5 million in the last election cycle. For residents, it's only $100 to give a shift, which is much less than the $1,000 that attendings have to give. And when I first donated, I had come to this conference, and I kind of thought about what I was getting out of this conference, both the tangible things, the lunches and the book and the handouts, but also the intangible things, the people that I was getting to meet, the things that I was learning about, the opportunities I was having. And since I was funded under the Chairs Challenge, I thought, I really want to give back. And so I gave a shift at that time. The EM Action Fund, Dr. Sama addressed, but it's the newest player on the block, and EMRA is involved in it, and it's really going to be working on mostly the regulatory issues. So healthcare reform's been passed, but many things need to be implemented and worked out, and the kinks need to be figured out, and they're trying to figure out how to work on quality measures, and these are the details that are really going to affect us in our practice as young physicians. So the Action Fund is going to be working on those regulatory issues, and if you'd like to donate to that, that's going to be key in the next couple of years. So I just urge you to find a way to get involved. Money, no money, a little bit of time. If you can go back to your residency and give a lecture or a journal club on advocacy-related issues, you can really spread the word about these important issues to the other residents in your program who didn't have the opportunity to come, although maybe they'll come next year. You can also speak out, the letters to the editor, the media training, tell your parents, because they're also voters, tell your friends and your family so that they understand the issues that are going into being an emergency physician. It's not just taking care of patients with heart attacks, but there's lots of things that are impacting your ability to provide care. So advocacy is a core competency. It's in the model of emergency medicine. It's something that we need to be learning about in residency and as part of our practice as young physicians. If you can bring it home to your fellow residents, then you will expand everyone's knowledge and understanding and build up our core of people who are active on these issues. The healthcare reform process has just begun. Implementation is going to be a huge process for emergency medicine, and we need all hands on deck to reach our goals. So I really thank you for coming to this conference and getting your knowledge base going and getting started, and I hope that you will continue to be involved in the coming months and years. So thank you very much for coming. If there's any questions, I can take those, and we'll keep going. Thanks. Questions yet? You can save them for after Nathan's lecture too, because he'll be going into more details on some of these issues. All right. At the end, I could.
Okay.
You need your mic.
Thank you. Put that on there. Put this in Brett's pocket.
All right.
Let's go back up to here.
Oh,
You?
yeah, that's me. Great.
See if that works. I didn't think it would.
It helps if I turn it on. So there we go.
You go.
Well, hi, folks. So I'm Nathan Schlicker, as Allison alluded to. So I hate standing on stages, so hopefully we can go mobile on this thing and try to get down here and chat. For all those that are sitting in the back, you're welcome to come forward, or if you're just walking in. So I'm also going to try to start this timer to keep me relatively on track. So we're going to do a little aid at first. Who here is a resident? Raise your hand. All right. Who here is a young physician? Who here is an old physician? Wow, some hands went up. Okay. Well, for those of you that are not young physicians or old physicians who are actually residents, what does ADIT stand for? Anybody know? Deafening silence, that's what I thought. Old physicians? No? Okay. So the first thing is acknowledging your audience or your patients. Your next thing is introducing who you are. So who I am, Nathan Schlicker. So these are my affiliations / conflict of interest. I don't think they're too much of a conflict. My kids are included on there. So they're only a conflict in actually getting out of the house to come here. We're going to talk for about 30 minutes. If there's any delays, I apologize in advance. I thank you for coming. So one of the things we never learn about as residents, like advocacy, is how to actually talk to patients. AIDED is a tool of that, and it's something I guarantee you every one of you will hear about when you get out to be an attending from your people who are saying, your satisfaction scores have to be higher, Ashley. You're only at 25 or 75%, and we need you at 90% because otherwise our dear friends in the feds are not going to pay us money. So AIDET will be the tool you'll hear about. But how many of us ever learn about that in residency? How many of us ever learn about any of these issues? You spend any time talking about Medicare or Medicaid in most residencies other than to say they exist? I doubt it. So we're going to talk about a bunch of these issues. We're going to talk about some of the things under PPACA. We're going to talk about some local issues as well, and then a little bit about how to get involved, okay? Please interrupt me at any time and ask questions. So what are ACOs? Accountable care organizations, and the head of the health policy committee, I'd hope you'd know that one, Aaron. But yes, Aaron is exactly right. Accountable care organizations. What are they? They're basically HMOs. Let's break it down to the simple stuff. They're part of PPACA or ACA, however you want to use the term, and they're a new form of delivery payment. They're here to help bend the cost curve. We're going to save money, people. And how are we going to save money? We're not going to pay you. We're going to make it simple. It's really easy to save money by not spending it. The feds don't get that except for when it comes to paying us. And capitation is the key. So these systems generally have to have about 5,000 enrollees of Medicare or Medicaid. They are going to pay you a set dollar amount. We're going to pay you $5,000 per Medicare and Medicaid enrollee. Sounds like a great plan, right? We did this with HMOs 20 years ago. It worked beautifully. Oh, wait. That's right. People didn't get access to care. People were getting harmed. So we're going to make it better. We're going to tie in PQRI. We're going to take all those performance quality measures that we're doing, and we're going to take those and we're going to roll them in so you have to provide good quality of care because PQRI means good quality of care, right? Without PQRI, you wouldn't give an aspirin to a heart attack. I know you're all bad doctors, right? What a ridiculous thing that we report on aspirin on arrival. And when you get 98%, do you really think that that was because you didn't give aspirin to a patient who needed it? Or is it because you forgot to write it down, or they got it in the ambulance, or they're allergic to it, or they're unconscious, or they weren't there for an MI, and did you know that Medicare penalizes you for a patient who leaves the hospital with a non-STEMI or STEMI diagnosis, who had that STEMI while an inpatient 3 months after they came through your emergency department? That's what we report on. So if you don't document why you didn't give an aspirin on arrival for a patient who came in with a toe pain, who the hospital has managed to cause a heart attack in, because they're good at that, you will not get paid a percentage of your income in the future. Does that have anything to do with good quality of care? No. So that's how we're doing this. We're working on rolling ACOs in to make it capitation plus PQRI plus all-inclusive cares. So when you hear ACOs, I want you to think HMOs. Now, are there good things that are going to come with this? Probably. We're going to all work for hospitals. Yippee-ki-yay. Hospitals do a great job, right? What's their overall effect? They're going to focus on a couple of things. They're going to allow you to work for a hospital. If you want to join a hospital, non-democratic, company-run group, there's nothing better than a hospital. And they will have lots of employment opportunities because most of these have to employ all service lines. So for instance, I work for the Franciscans, I'm part of Team Health. The Franciscans, we have hospital-owned everything. We bought up neurology, urology. We bought up orthopedics. We just bought 20 cardiologists this last week. Seriously, we got cardiologists coming out our wazoo. I don't know what the other guys in town are going to do. Sorry, Allison. She's going to my competing organization. So, anytime the Franciscans get a win, I do have to, gloat a little. We're buying everything. But 20 years ago, most ER docs left the practice of hospitals, right? We said hospitals don't do a very good job. They don't bill well. One of the private groups I worked for in residency, that was one of our residency groups, they gave us a lot of lectures and I said, why did you guys leave the hospital? He goes, well, we did an audit of the last 6 months. And for our 60,000 visit ED that's geriatric heavy, that's got an admission rate of about 35%, they had billed for 1 intubation and 6 central lines. In 6 months, 30,000 visits. Anybody think that's accurate? I don't think so. So I'm sure they'll get better, though. I'm sure there'll be quality metrics on how effectively let's not even go there. So there's a few issues with ACOs, but I don't want you to be all bad. We're going to have more Medicaid, right? Medicaid's going to solve our problem. You saw Allison slides. Medicaid went from tiny little sliver to big old pie. Medicaid's the answer. We're going to expand the federal poverty level. We're going to make this a better country by putting CMS in charge of more patients. Yes. Anybody know how Medicaid's run? Poorly, yes. Who said poorly? I believe it was you. Is it, let's see, Caleb. So, Caleb, who runs Medicaid? CMS, yes. Who administers Medicaid? The states. And just like there's 50 voices whispering states in this room, there are 50 entities running Medicaid right now. It's a hybrid program and there's optional add-ons, the S-CHIPs, the other little expanding the federal poverty level. There's ways that you as a state can say, we're not going to take the base Medicaid, we're going to make it more. What's happened in the last 2 years? All those add-ons are gone. I mean, we in Washington have basic health. That puppy is on life support. It's getting CPR down at the state capitol right now because we were going to cut it, and everybody said, no, we can't do that. We can't screw the poor. So we're going to help them by keeping only 30,000 of them, and what was once 120,000, well, the other 90,000, I guess they're not poor enough to qualify. It's great logic. This is kind of what happened. Medicaid has gotten the boot in a lot of states. If you look at Maine right now, they're affecting surgeons. If you come back for a surgical complication, they're not going to pay you for it at the end of the day. Now, how do you get around that if you're a surgeon? Because like everything the government tries to do to cut costs actually increases it, right? So how do we make this a worse system by putting in cost savings? As long as they don't get admitted to you again, but to a different surgeon, you get paid. So I do your surgery, John, and I'm going to have my friend here come and take care of you afterwards. He doesn't know what we did, what went wrong with your surgery, but at least this way we both get paid when you have a surgical complication. Makes sense to me. Better quality care, less costs. Oh, wait, it's going to cost us more. Because now you're a separate physician, Jonathan, and rather than it being a follow-up visit, it's an all-new visit. So we got an extra billing. Saving money, saving money. That's what it's all about. We've got to bend that cost curve. In Washington, there's a new great way that is, my current headache, and we'll talk a little bit about it. We're only going to pay for 3 visits. Medicaid patients only come in 3 times a year, right? Yeah, right. And in Texas, they've considered just completely dropping the thing. We're just going to do away with Medicaid. Now, I think reasonably that's probably not going to happen. It's a lovely political gerrymandering, standing on a stage, beating your fist, but, it's out there. So our experience, that whole reasonable, prudent layperson standard, it may apply, but not so much to the feds. At least that's what our state CMO of Medicaid is saying. Reasonable, prudent layperson does not apply to us because we're feds and the state can't make us do it. And it's a state-based law. Now, PPAC is going to bring that in, but it's unclear whether or not that will be included, and he's arguing it won't be because it's a federal program, and it doesn't apply to federal programs. It only applies to private companies. So your health exchanges, your Medicaid HMOs are subject to state-based or the reasonable prudent layperson standard, but CMS itself may not be. It's a novel idea. And such things that are considered to be non-urgent conditions include coma, asthma exacerbation, vaginal bleeding in pregnancy, chest pain, abdominal pain, UTIs, cellulitis, or cholecystitis. Now, it's actually a list that includes Excel line spreadsheets for 7 pages of things that are not going to be paid for by our state Medicaid as non-urgent. Yeah, that's what it is. And I asked the head of Medicaid in our state, I said, so you're telling me if a 55-year-old diabetic, hypertensive, hyperlipidemic male with known ACS comes into my emergency department complaining of chest pain, and he's had 25 visits for the same this year, I don't even need to do an EKG? Looked me right in and said, nope, you don't. I said, you are out of your frickin' mind. And he's an internist, so that maybe go without saying, but that's honestly their perspective. You can cut costs. Once they've been there 25 times, nothing bad happens to our frequent flyers, right? Anybody heard of fast-track disasters? But I'm sure medical liability was part of this. Oh, wait, it wasn't. We got rid of that early on in PPACA. But there's hope still, right, for medical liability reform? I see a few shaking their head in the back. Dr. Claus, yeah, so maybe you're right. But why do we care about this? Why do we care about defensive medicine? Well, the reality is that we spend $20 billion a year in insurance premiums. Now, out of couple $1 trillion budget, maybe not so much, maybe budget dust, but it's a decent amount of money. And cases are costing more and more. 50% now exceed $1 million. Who here has more than $1 million in coverage? If you're a resident, you can raise your hand because you've got a bottomless pit behind you, which is why it's great to work for a hospital. So that may be the only reason to go for an ACO, is it's great to work for a hospital. They're the deep pocket. But everybody else, most insurance policies for ER docs are $1 million. The only people that have more than that generally are OBs at 5 or maybe 10, but most obstetrical verdicts run more along the lines of bad baby-wise, 10 to 20 million. We've settled some in the 8-digit range. And there's some in other states that are even higher, but it's expensive. And the costs are crazy and they're hard to calculate. Maybe Jeff Thompson, our head of CMO of Medicaid, is right. Maybe we don't need an EKG on the guy who's been there 50 times in the last week for his chest pain. But that's sure not the standard of care, is it? It's definitely be sued if this is the one time he's having his MI. So unless we fix this, how are you going to get docs to stop doing defensive medicine? How are you going to stop getting a CBC and a CMP on every patient who comes in with nausea and vomiting because, well, if they have a white count, I might get a CT, or if they have, an elevated LFTs, it might have meant something, or whatever reason you have that you order a test, that we can all agree is probably not super necessary. How many times, if you're a senior resident or a young physician, has a resident walked up to you and said, well, I ordered some baseline labs on this patient, and your question was why? And they said, well, because we always do. That's the truth, isn't it? We always do things. So there is real costs here that we talk about that are our habits and behaviors, generally because of defensive medicine, estimated to be maybe as high as 30% of all dollars that we spend. It's not insignificant. What are some of the options? Allison alluded to them. Malpractice caps are probably the one that's heard the most. But I bet you, and I would tell you, what's the most effective means? It's raising the standard of evidence. Most states are just 51%. You raise it to willful and wanton negligence, reckless disregard, even clear and convincing rather than preponderance of the evidence, and your malpractice rates will go down. Because right now it's a coin flip. And so in some states it's how many experts can I pay for on my side to outweigh your experts. Sometimes it's who speaks better. Let's be honest. Some of the smartest people we know who write the test books, they're just like snoozing. They are, and some of them are great speakers, and that's wonderful. But oftentimes, it's some guy from California, sorry if there's some Californians in the room, who isn't practicing, who is an expert witness for hire that makes $400,000 a year flying around the country giving expert opinions. You need an OB to testify tomorrow that there was a bad care in OB case, Barry Schiffbein, give you his number. Down in California, makes $400K a year testifying for plaintiffs. Doesn't practice anymore. Why? Why take the risk when you can get all the money? Brilliant guy. Expert witness qualifications, making sure that Barry isn't practicing anymore would be a great thing. Saying you actually have to practice clinically to testify about what the clinical standard of care is. That would seem to be common sense. Not a requirement in most states. Been fought tooth and nail in some states because plaintiffs' attorneys love their hire guns because Barry he's a fine wine. He can testify real well. He speaks real good. And Barry is very eloquent when it comes to making his point and making sure that his side looks the best. Even though in one case we had Gabby, and if anybody's an obstetrician, Gabby's the guy who writes the textbook and it's his name on the textbook. And we had Gabby. And Gabby actually did a very good job when we won the case for some other reasons, but Barry made a good show of it. And he's a schmo that's hired off the side of the street corner who makes a lot of money and has nothing to do with the practice of medicine. And the guy who writes the textbook who's on our side is having to fight as though they're equal contestants on this thing. It's silly. So where do we stand? With that positive news, I stole this sign from Nick Girillis, and I just love it. So at least now we stand a chance. But many issues remain. Lawyers are very powerful. We talked about the PAC money. You saw it. We're now up to a couple million, right? The plaintiff's bar is about 6 to 8 million most times in the same cycle. And do we play well together as physicians? No, we have 75 frickin' PACs. Lawyers have like one for plaintiff's bar. They're good at pooling their resources and pooling their money to get what they want, which is to not get caps. and to not raise the standard of, of evidence required. They're very, very, very good at that. We have to learn to play well in the sand, and we have to be the champions of this process. And we need to look at it not about money, because at the end of the day, you're all a bunch of greedy, self-serving doctors, every single last one of you. And when you mention money up on Capitol Hill, that's what they hear, and that's what they think. Because you make a living that exceeds the living of most people in this country by an order of magnitude of 10. So when we go to the Hill to talk about money, it is a lead balloon. What are we really talking about when we talk about medical liability reform and less defensive medicine? We're talking about patient care. We're talking about quality of care. We are talking about access to care. It's the driver and it's the problem, and it does affect our income, but at the end of the day, it's about access and quality of care. And that's what your messaging is when you get to the Hill. It's not at all about the money. It's great to talk about the money here in this room, but when we are up on the Hill, it is about access and quality of care. And this is an access issue. This is a quality of care issue. If we stop doing some of the things that we put patients at harm for, the 7 belly CTs in a year because they might just have something that's causing cancer. The kid who falls and hit their head and their parents are histrionic, screaming they're going to sue you if you don't do a head CT. So what do? You stuff the kid in the scanner. Maybe a 1 in 10, 1 in 100 risk of cancer. Yeah, these are real things that affect patients every day. We've got to fight on those grounds. There's the iPad, another great issue. If it's as effective as my iPad is, it's going to be a total cluster, because I edited my presentation on my iPad on the way here, and it got all screwed up and couldn't get it off the damn thing. Never doing that again. But the IPAB is a 15-member board that's going to be established by the president. They're going to make about $130K a year. Is there any requirement that anyone be a physician? No. So it's going to go into effect for us about 2015. Hospitals, though, being the smart people that they are with a big lobby, they said, well, don't apply it to us till 2020. Let's see how it goes for the docs first. Why? As Allison alluded to, cost is out of control, and MedPAC is not doing its job. The SGR is not working to rein in costs. We are growing at an exponential rate, and Congress is, at the end of the day, too politically weak to do anything about it. They're not going to impose a 30% cost cut on us and kick old people out into the street. That's not what they're going to do, because who takes Medicare and Medicaid besides us? Not many people. And so what are they going to do? They're going to make the IPAB the way to do it. They're going to say, we're going to target $28 billion in cuts. We're not going to tell you how to do it, IPAB, but here's the money, and here's where we're spending it, and you figure out how to cut it. So they might do some things that some states are doing. They're going to stop paying for silly things. If you've got a BMI of 21, you're not getting a gastric bypass surgery. Liposuction is not on the approved benefits list of Medicaid, kind of stuff. That'll save some cash. But at the end of the day, we're going to have to cut reimbursement, right? But now what's the benefit if you're not the IPAB in your Congress? I didn't do it. It was an independent body that decided this, made up of citizens that felt this was the right thing to do. Now, just because their hands were tied behind their back when they were making the decision, we're going to overlook that little detail. That's not an important detail. And there's no physicians to be required to be on the board. It's kind of funny. You wouldn't ask an airline pilot how to make an airline safer by asking a bunch of people sitting on the plane to improve safety. I mean, it's just kind of silly. We need people on there that actually know what they're talking about. Balance billing, another great hot button issue. Anybody know what balance billing is? So balance billing is the opportunity to, again, cut your reimbursement and increase your care requirements. Balance billing is when a patient receives a bill for an out-of-network service, or the differential between what is reimbursed on their insurance and what you billed. When you're an in-contract, in-service provider, and you're in the network, as we would say, you have a contractual agreement with their insurance carrier that says we will get paid XYZ dollars. When you're out of network, you send them whatever bill you want. Do those two things look at all alike? No. Your bill will be exponentially higher on 2 to 5 times the range of what's actually paid. So the people who are out of network get this massive bill. Insurance companies say, that's not fair to us. You're not contracting with us, so we don't want to pay you. So in California, they said, well, yeah, that's not fair to send that bill to the patient. It's between the insurers and the physicians, and they need to work it out. So we're not going to let you balance bill anymore. What's the side effect of that? What is your incentive to contract with the physician if you're the insurer? None. Because at the end of the day, you can just say, oh, we don't want to pay your bill. We're not going to pay you for it. You're out of network. And you can't bill the patient, so you have no recourse. Real problem. Other states have had the same issue. Florida, said that it's illegal to balance in emergency situations. Oops, who does that affect? All of us. In Washington, there was a push for the balance billing this year. We fought it off the last 2 years. We tried to get it into a reporting measure. Usual customary rate, Medicare, or the median in-contract rate was our other compromise if we couldn't get rid of it, was to say we'll pick the higher of those three. Some states have done, well, if you don't get paid the going insurance rate, then Medicaid is your default rate. That's a great reimbursement strategy. And right now we've defeated it. To be honest, it's converted to a reporting measure, but it's coming back. This is coming up right now because they're in budgetary session, so anything that was once dead can come alive if it affects the budget. And so it can get resurrected at literally the 29th hour and come back and bite you. We're also filing a suit against them to say that they have to enforce a provision that was a consent decree that the insurance company agreed to, that the state insurance regulator said he didn't really think applied anymore. What the original consent decree was, the insurers agreed that they would pay that out-of-contract bill and only bill the patient an additional $50. Kreidler said, I don't think that's how it's read. We said, how's it read? He goes, I really don't think it applies. I said, well, what do you mean? Well, I don't think we should use that. I said, well, but we agreed on a consent decree that should be enforced. No. So now we're suing him to get him to enforce this, something that everybody agreed to. But at the end of the day, these are all great high-level concepts that involve coming to the Hill, but all politics is local, isn't it? Where do you do most of your advocacy? It's day in, day out. Dealing with consultants, boarding, all these issues, fighting about them, and it's important to do it. Hospitals are a hotbed of politics. What are they in most cities? They are the pillars of the community. They're also often the largest institution. Many of them are faith-based and have a moral high ground to stand upon. We are not a faith-based organization as ACEP, so we don't have a moral high ground to stand upon. We have a lot of other moral reasons, but we don't have that one to stand on. There's a lot of egos involved. A lot of these people are MBA CEOs that are very powerful and think they know a lot more than you do, and will remind you of that fact on a regular basis, and or will try nicely to say it in another way. They're also non-clinicians, so it's easy to say, well, we see you're spending a lot of money on this repetitive care, but why can't you just stop doing that? Just stop it. It doesn't work that way, right? Clinical care is different. But when they're seeing it dollars and cents on a paper, they think we're just being ridiculous and not fixing these things. They also, want to demand things. They'll say, I want your Press-Ganey scores to be at the 99th percentile. Well, that's great. How am I going to do that? I work in a shop that's got 20 beds sometimes out of my 40 beds that are filled with inpatients. I'm seeing 180 patients a day, with sometimes 70 to 80% of my patients in hall beds. I admitted a guy from a chair without a monitor into the ICU the other day. Yes, Press-Ganeys were looking good that day. There's another hot button issue at my hospital, violence. It's been escalating nationally. It's in many of your EDs. You see it every day. Docs are getting killed, nurses are getting killed. We had a guy walk into triage at the neighboring facility, Allison's, and pull out a gun in front of their metal detector and shoot himself. You heard about it, right? It was in the national news. Didn't even make our local papers. Didn't even make the local news. We had a guy walk into triage and throw bullets at our secretary. Another guy in the last 6 months walk in, hand a gun, and say, can you please take this? I feel like shooting people. And when asked why and who, he said, well, right now I want to shoot you. To our intake nurse. Anybody seeing violence in their ED? No. My response when I first brought this up was, it's too expensive. We have a committee to study it. These were all honest to God things I heard. We can't do this here. We're a Catholic hospital. It's against our values to search our patients. We believe in their privacy too much. And my favorite of all, when you're dealing with an administrator, we put out a memo to deal with violence. We know from TG's data they're getting 10 weapons a day, 8 guns a month into their department, and they're 6 blocks from us. And my response was, well, we've got a memo. You can imagine I was not the most friendly person to deal with on that committee. But you find ways to go around them. And this is what I encourage you to do, is don't get stopped when somebody tells you no. It's not the most politically sensitive or appropriate thing, but when I was a freshman in college, our 80-some-year-old college football coach was trying to rally up the troops, and he said, just remember, no doesn't mean no, it means maybe, which was not the appropriate thing in a college setting, but in this setting, it's totally appropriate. No doesn't mean no, it means maybe. So I took it around her. I went to the COO of our hospital administration and skipped over our president. This hospital administrator agreed with me on 3 important things. We're getting an outside consultant in to come do a site-based visit to each of our institutions and look at our safety, not just the issue of metal detectors, but to bring them in and look at it. I got a commitment from him that we would do a rapid process improvement to look at it from the staff's perspective and get their buy-in. And most importantly, I drug out of him a firm deadline of 3 months. Said, we got to get this done in 3 months. He said, I think we can get it done in a month. And I said, I think you're crazy, but I love your enthusiasm. Let's do 3 months and let's get the staff something real. And we engaged the staff to make this happen. You have to be a leader in not just taking the issue and beating your own drum, but bringing 100 drums behind you. Without even mentioning it, the staff put together a petition, and 80 out of my 110 line nurses said that they signed a petition that they wanted metal detectors in our department. That's very powerful when you can walk up to your COO of your hospital administration system and say, I've got a petition from your employees, not the ER docs, your employees, that they want this and that they don't feel safe in your department. Now, I got labeled as a troublemaker, but hey, it gets it done. So how do we do this? Anybody know who this guy is? Desmond Tutu. So Desmond Tutu came to Tacoma actually last week and gave a lecture at Be the Spark. It was an event that was hosted in the community. About 15,000 people came, sponsored by my great Catholic institution, the Franciscan Health Systems, with our CEO up there on stage with him. And his big message was, and I think it's something that we all need to remember, is be the spark. And this is what the whole event was about. You don't have to do this by yourself, but you have to be the one that sparks the idea. You have to be the one that becomes the champion for the cause and takes it forward. If it's the violence issue, for me, I went in there and made a lot of people mad. But now my nursing directors are taking this up and running with it. So it's not my voice alone, it's 5 nursing managers from 5 of our facilities speaking, saying that this issue needs to be resolved, and I kept my mouth shut at the next meeting, mostly. Hammond was there. I did pretty good, right? Okay, all right, I did okay. But if you can spark people and get them energized and get them involved, then they'll take this issue up and they'll run with it. They will be the voice that does it. You just have to start the process. But why do we do this? It's for the people in our lives, the people who are practicing physicians alongside of us. It's for our patients. It's for our families at the end of the day. That's why we're here. And I want you to remember that. We're not here fighting to get better reimbursement. That's part of it. But it's because we want to provide for our families. It's because I don't want the Medicaid patient that's a 15-year-old girl who comes into my emergency department for what's thought to be a Benadryl overreaction on her 4th visit, feeling like she can't come to my hospital next time because Medicaid says she's on her 4th non-urgent visit. When that young lady ends up dying 6 hours later because she's the index case of H1N1 in my state. And I spend 4 hours coding her. I don't want that person dying on the street. I want them to feel like they can come to the ER when something is wrong. Like they will get care day in and day out at our institutions, and they have that access to care. That's why we fight this issue. And remember those personal stories. Remember your patients. Remember your colleagues. When you're dealing with violence, bring up the stories of the people that have been affected by it. When you're dealing with Medicaid, think of the access and the people you've seen that wouldn't come to your emergency departments, because that is what's going to win the day. Talking about money never will. But how do we do this? I'm sure you all got training on leadership and residency, right? College, medical school, residency? Never, maybe? I mean, we talk a lot about advocacy at leadership and advocacy, but we don't always talk about leadership. What the hell? Oh, that was my timer. I told you this iPad thing is killing me. Get it for the wife and bring it as my first substitution for a laptop, and it's just been one pain in the neck after another. But I gave myself 5 extra minutes at the end so that I would know to hurry up. So what I want to say is, leadership, something that is not something that we're all born with. How many think you're above average leaders? I bet you all raise your hand because you're here today. But it's hard to be above 50% on an average, right? Not everybody can be. It's like if you poll U.S. drivers, how many think they're above average drivers? 75%. It's a great statistic. I just love that one. Leaders are rarely born, but you're expected to be a leader every day in your department. And I know you guys get that because you're here today to advocate on a national level and to learn about these issues, but I encourage you to take this message back to your colleagues. Every day that you're on a shift, you're a leader. You're a leader of nurses and techs and secretaries. You are a leader who is expected to make a department that's not functioning run. And when you walk into a department and you say, you mean I've got to work out a triage again today because the damn inpatients are taking up all my beds? I don't know how I can work like this. What do the nurses do? Yeah, you know, they get in there and they're angry too. So now everybody's angry. Does that help the situation at all? No. But is it our natural response? You darn well better believe it. And I would encourage you that you've got to fight those natural instincts to be a leader. Say, we're going to take the worst situation, we're going to make it the best. There's no reason that we can't work out of VXT. Yes, a chair going to the ICU may be a little extreme. We got to adjust that a little bit. But we can find a happy medium. We can find a way to make it work. We can get this done. Be that leader. Be that voice that gets things done. Learn the lingo. You know, you'll hear when you get more involved in leadership about gembaing. Has anybody gemba'd before? No gembers? God, I've spent too much time doing this stuff recently. Gembaing is going and walking the walk so that you understand the challenges. If you're walking in an ED and you're understanding that I've got to go here to get my charts and I've got to go here to see my patients and I've got to go over here to get my test x-rays, I'm going to learn that I want to consolidate all that and bring it into one. Walk the gemba. It sounds cheesy, I swear, but once you've said it like 50 times, it's actually kind of fun. You know, rapid process improvements, lean projects, 5S'ing it, 6 Sigmaing it, split flowing it, learning the checklist. All these things are, you know, ways that you can get involved in being leadership and learn the lingo. There's so many ways that you can change your department without ever coming to this meeting, or that you can change medicine by coming to this meeting and never being involved in your department. Pick one, get involved. You'll make mistakes. It's okay. You'll piss off the CEO of your hospital. They'll probably forgive you most times, especially because you're young and they forgive us because they're old. Sorry, old guys in the room. I look over there at you guys because there was a concentration. But they'll forgive you. I was looking at Andy and some of the other tables, but you know, they'll forgive you. You'll learn. Don't stop. Don't ever think you know everything about this. This is my 4th meeting in the last 28 days, spanning San Diego, Florida, Seattle, and DC. I learned something in every single one of these. Seriously. Every time I come to an event and I hear somebody speak about leadership, I'm like, wow, why aren't we doing that? For my doc, since I'm the associate director of our department, I was at a meeting and I learned about red light, green light, and not the game that children play, but red light, green light, stoplight reports, about updating your people on what you're doing every day. And it's a simple Excel spreadsheet with red light, green light, yellow light that says where we're at on issues. I'm like, what a genius idea. Because what do most line docs complain about? You haven't done anything for me recently. My issue isn't fixed. And it's like, well, I'm working on it, but you know, the hospital doesn't move at light speed. I know we do in the ER, but getting anything done in 3 months is a miracle. 6 months is good. A year is expected. I mean, come on. Give me a break, but just updating them. I said, that's a brilliant idea. I'm taking that home with me. I'm putting it in my department. Join a club. You're all here today because you're part of a club. ACEP is a club. You need to collect your voices and, you know, make a team. Teamwork is so important in all of this, and that's what I encourage every day, is at home, be a team. Don't say that it's the nurses and the doctors. It's the team. We work side by side in the ER unlike any other group in a hospital setting. When my wife got her 90th percentile and greater Press-Ganey recognition award from the hospital she works at, there were 7 ER docs, 2 urgent care docs, and about 9 inpatient docs. 50% of the people who were getting awards for having the highest satisfaction in their institution came from ER and urgent care.